Yeah, we are live now. So,
Yes.
good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar. And today we are back with our series Med Mocha Meetup Season 1 and Session 13. Today's topic is on FGR and Colour Doppler in third trimester. So let me introduce the organizer of this webinar, Dr. Ritu Santwani ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is consultant obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio. Ma'am is also infertility specialist. Ma'am is part of NUHS Singapore, co-founder of MAAM and board member of SWWC. So I welcome you, ma'am, and I hand over the session to you.
Yeah. Thank you, Sahiti, and thank you, Shield Pharma, for providing the platform for this program from the last 3 years. Knowledge is power. Knowledge always increases by sharing. With this motto, I initiated this series at the time of the lockdown. So I can say by the grace of my Mata Rani blessings and supports of the stalwarts like Kuldeep Singh sir, the program is still going very well. And the program is popular all across the geography. You can see a lot of friends have joined across the globe. I am able to see some friends have joined from Cairo, some from Africa, and from the other countries also. So today we are having a very eminent speaker, Dr. Kuldeep Singh sir. Sir, for sir, I can say the one line, sir, is the ocean of knowledge. So, and he's always ready to share his immense knowledge with all of us. So today, sir is going to discuss with us regarding the FGR and color Doppler in third trimester. Related to that, we all are having lot of queries. So may I request Sahiti, will you please do the introduction of the sir?
Yes, ma'am. Yeah, it's my honor to introduce Dr. Kuldeep Singh sir. Sir is the master trainer in the field of ultrasound, and the sir is practicing ultrasound in New Delhi and is known for his skills in ultrasound in obstetrics and gynecology and infertility. Sir has given more than 600 talks in national and international platforms. Sir has been invited to share his academic experience in Japan, France, Spain, Belgrade, Dubai, Seoul, Dhaka, Kathmandu, London, Zurich, and Singapore. Sir has received 4 awards and 3 gold medals in the field of ultrasound. And Sir has authored 16 books on ultrasound in obstetrics and gynecology and infertility. Sir has written many books and have translated into Spanish, Chinese, and Portuguese. Sir has received many awards in and awarded the Imaging Science Award in AICOG in Delhi. Sir is successfully running Sono School, which organizes various training programs in ultrasound in obstetrics and gynecology and infertility. Sir has delivered the prestigious Dr. V.N. Shirodkar oration in Solapur. So I welcome you, sir, and I hand the session to you.
Warm welcome, sir. Warm welcome, sir. So you can see your popularity. Lot of doctors have joined all across the geography to hear you. Really,
Thank you
I'm
so much.
thankful to you that you have accepted the invitation. We all are eagerly waiting to hear you.
Thanks so much, Ritu. Thank you. It's always a pleasure to be with you, and you come up with some bright ideas, and that's always really nice. So I'll start sharing my screen. I hope I should be audible, and if there's any problem, do let me
Yes.
know so that I can
Yes.
always yell a little more louder. Is my screen visible?
Yes, sir.
Yes, visible, sir.
Fine. Is the topic on color Doppler and aid in diagnosing, managing, and timely termination? Is it on? Are we able to see it?
Yes, sir.
Because
Yes,
I don't
sir.
know,
Yes.
the platform seems to have changed a little bit. So things, or might be I'm using this laptop for the first time. I normally sit from the clinic. Good evening, delegates. We're going to talk on this very important topic, and that's color Doppler and how do we use it in the third trimester. It's not only whether how am I going to be able to do the ultrasound, it's also how I'm going to be able to interpret the ultrasound. So be very watchful. And always in a talk or in a CME or in a conference, it's not that you're going to collect 100 points. It's just always you're going to be having those 2 or 3 important messages which you're going to put to clinical use. Plenty of you members of Sono School. Otherwise, you can always check with Dr. Ritu. And if anybody wants to join Sono School, you're most welcome. We go by the phenomenon of we question, you answer and learn. And there are two basic dictums that we follow at Sono School. One is the eyes are going to see what the mind knows. Secondly, if anyone can do it, you definitely can do it. Now, coming on to the basic definitions, and we need to be very, very clear on this. An SGA fetus is a fetus with a weight below the 10th percentile. But the good thing is the baby is otherwise healthy, has a relatively low risk for perinatal morbidity and mortality. FGR fetus is a weight below the 3rd percentile, or if I'm looking at below the 10th percentile, I have to be having Doppler abnormalities with it, and we're going to touch upon Doppler today. We need to remember there are plenty of things and changes that are happening in maternal and fetal circulation. Until we had Doppler, we were not able to check on that. We were doing the blood gas analysis, the biochemistry analysis, the fetal heart rate analysis, and trying and figuring out. But we have Doppler in our help, and we're going to figure out the improved diagnosis of both FGR and SGA. SGA means a normal fetal Doppler. FGR, because of placental disease, exhibit maternal and fetal Doppler abnormalities. Again, the same thing in a tabular form, less than the 10th, FGR less than the 3rd, or less than the 10th with Doppler changes. There are two phenotypes of FGR, early onset and late onset, and the cutoff is 32 weeks. When does it start? The evolution, the Doppler parameters, and the postnatal outcome. Antenatal diagnosis, treatment, and timely delivery are going to diminish the risk significantly. What am I worried about? I'm worried about mortality, morbidity to the mother, to the baby. And if I know when is the right time to intervene, I'll be in a much better position to help out. What are the key messages that I need to start off with? I need to have a detailed maternal history. My dating has to be absolutely accurate. And remember, you're supposed to date only once in pregnancy. You can't be dating it at 8 weeks, at 12 weeks, at 20 weeks. You're going to be making a mistake. The fetal size is assessed by the estimated fetal weight. There is something called as the fetal size. There's something called as the fetal growth, which is growth velocity. And that you're going to be assessing by growth charts. Do not use your machine values blindly. You are supreme. You have to have faith on yourself. Do not go ahead with what the machine is telling you. Then the FGR and placental dysfunction, what all are we monitoring? We're looking at biometry and growth charts. We're looking at compensatory mechanism. We're trying to predict hypoxia and acidemia. And we're trying to look in at the fetal environment through CTG, AFI, and the biophysical profile. That's a bit about fetal circulation. The blood comes into by the umbilical vein. It goes into the liver, most of it, from the ductus venosus, left atrium, goes from the right atrium to the left atrium, foramen vein, left ventricle, and the purest form, the red one, goes to the brain. Then it all comes back. The other portion comes back via the ductus arteriosus, goes into the aorta via the hypogastric arteries, goes back in the form of umbilical arteries back to the placenta. So we need to be aware of what all things are going to be happening. The highest concentration of oxygen and substrates via the umbilical vein. The first shunt is the ductus venosus. This is basically going to be taking the blood from the inferior vena cava is a double channel vessel. First takes off the deoxygenated blood, but via the ductus venosus. Because the umbilical vein is wider, ductus venosus is narrower, the speed increases, and via the right atrium, foramen ovale, left atrium, left ventricle to the brain is the purest form of blood because of the ductus venosus. That's why there is so much of importance for the ductus venosus. And please do not worry that it's such a short vessel. Will I be able to do it? You will be. And if somebody else is doing it for you, always check the charts. And I'm going to be showing you how you're going to be interpreting the waveforms. Then the blood comes into the heart. And we have the ductus venosus, left hepatic vein carrying blood with high nutrition content. The left side, the pulmonary veins. Normally what happens when the baby is born? The ductus venosus goes away, the ductus arteriosus goes away, the purest form of blood, which is purified in the lungs, comes back via the pulmonary veins into the left atrium. The foramen ovale is the second shunt in the baby. Different direction, different velocities, the saturated blood from the ductus venosus reaches left ventricle preferentially. Depleted blood enters the right ventricle. Then we have the pre-ductal aorta, before the ductus joins. The nutrient-rich blood is supplied to the myocardium and the brain. Less saturated blood from the right ventricle reaches the lungs, ductus arteriosus, which is a conduit between two blood streams. Do not worry about these theoretical aspects. How are we going to interpret it? I'm going to be letting you know. Aortic isthmus. That is the last portion of the arch of aorta before it joins the ductus arteriosus. After the left subclavian artery is given off, that portion is the aortic isthmus. And that is again shunting between the left and the right side. The umbilical arteries are the fourth shunt where the depleted blood is channeled back to the placenta to get back gas, nutrients, and fluid exchange. How do you interpret fetal arterial Doppler? Severe fetal redistribution would normally be followed within 2 weeks by the development of reduced biophysical profile, abnormal venous Dopplers, and suboptimal CTG. A growth-restricted fetus would usually develop an abnormal umbilical artery before developing fetal arterial redistribution. Now, most important, and always be careful of seeing the films, is the calculation of the cerebroplacental ratio. This is the ratio of the middle cerebral artery pulsatility index divided by the umbilical artery pulsatility index. And if this is less than 1, we know it's abnormal. For a late onset FGR, this is the cutoff point where you need to deliver. For early onset, it is reversal of flow in the ductus venosus when you need to deliver irrespective. So this is the most sensitive marker for redistribution. A CPR of less than 1, earliest sign, and very sensitive in late onset FGR. Now the question is, do I need to again and again go onto the calculator and calculate it? Well, you can always go onto Google, put it in the percentile charts of the ECOG or the FMF guidelines. Otherwise, the best is looking at the umbilical artery PI. If this value is more than this, you know the value is less than 1. Meaning, if the denominator is more than the numerator, the value is going to be less than 1. And you'll be very clear without calculating it. Abnormal CPR means high incidence of fetal distress, lower cord pH, and increased admission rate to the NICU. Now, where does we have this arterial Doppler, we have the CPR, but the venous Doppler is one which is extremely helpful, especially for early onset. Less than 30 weeks, if you need to prolong the pregnancy, because I'm looking at an absent or a reversal in diastolic flow, I need to be giving them therapy for accelerating fetal lung maturation. It's the venous Doppler that's going to decide. It provides additional non-invasive information on the functional capacity of the fetal heart. So if you're looking at absent or reverse in diastolic flow in the umbilical artery, it's the venous Doppler that's going to help you. Now, be careful in looking at this chart. We're going to start off with a growth lag. There is going to be less blood flow in the umbilical artery, more going in the middle cerebral artery. Redistribution. Weight is getting less. Gradually, you're looking at absent or reversed in diastolic flow, changes in the ductus venosus, finally oligohydramnios, and abnormal CTG. If I'm looking at 32 weeks or less, I can wait up to this point. But the moment I'm looking at 32 weeks or more, the moment the CPR is going abnormal, there is redistribution, I am going to be doing a termination of the pregnancy. Now, why is the chronic marker so important? Why is early onset and late onset so important? I'm looking at early onset FGR. The changes, chronic changes are happening in weeks. Acutely, things have a problem, and that happens in 7 to 10 days. I have time. I can look in at, I can monitor, I can call them every day or every 48 hours. Now, what happens in late onset? The problems are happening in weeks, but the acute changes happen in hours. So you won't even realize it. Today the baby was fine, just a little bit of FGR, so what? And day after the baby comes back and we're looking at an IUD or a stillborn baby. The same definitions which I've already given. So what is the protocol for FGR? Identify a small fetus. Looking at FGR versus SGA. FGR, so is it early versus late? What are the parameters for fetal follow-up and the stage-based management protocol? You're identifying a small fetus. How do you know it's truly small? Might be it was a delayed conception. So you always have to make sure that you've established the gestational age. However poor that report might be, always consult the very first ultrasound, whoever has done it. Estimate the fetal weight and calculate the weight percentiles. We come on to what are we doing in terms of each and every problem that we are encountering. You're looking at a small for gestational age, means the weight is less than the 10th percentile, but the Doppler values are normal. You're going to be seeing these mothers every fortnight, every 2 weeks, and assessing the growth, and you can go up to 40 weeks to deliver. I'm looking at a normal uterine artery, no notches, plenty of diastolic flow. That's the iliac vessel. The uterine artery has just crossed the iliac vessels and we insonate it there. And why is uterine artery so important? Because it tells me about whom to suspect for preeclampsia and FGR. It's a nice screening modality. This is how important the uterine artery Doppler is. It does not mean that if the uterine artery Doppler is normal, meaning there's going to be no problem of preeclampsia or FGR. No, the chances are less. If it is normal, the likelihood ratio is this for FGR, this for preeclampsia, and this for perinatal death. But if it is abnormal, it does not mean 100% there's going to be problem. The chances increase 5 times for FGR, 10 times for preeclampsia, and 3 times for perinatal death. You're looking at a free loop of cord, looking at 2 arteries and 1 vein over there. And the red and blue denotes flow towards or away from the transducer. You're looking at plenty of diastolic flow in the umbilical artery. You're looking at a normal PI. Whether you following the SD ratio or the RI or the PI does not matter as long as you have charts to support that. Normal flow in the umbilical artery. Looking at the middle cerebral artery, circle of Willis over there. I'm going to be insonating this so that I need to see whether because of the aortic body chemoreceptor stimulation, is there more blood flow going towards the vital organ, and the brain is the most vital organ. Normally, the middle cerebral artery is a high resistance circuit. This is not brain sparing, but if you're going to look at brain sparing, it's going to become a low resistance circuit, which I'll show you just now. Ductus venosus. Normally, blood is going to flow towards the liver, but this stream going towards the inferior vena cava with this sort of aliasing or turbulence over there, you know this is the ductus venosus. And it's going to give you this M-shaped pattern. Ventricular systole, ventricular diastole, and atrial systole. This is what's most important. This is what I'm interested in. ventricular systole, ventricular diastole, and atrial systole. If this goes lower or this goes absent, or if it's going reverse, I know I'm heading for trouble at each and every step. That means acidosis is ensuing. In terms of types of FGR, less than 32 weeks, early onset. They're easy to identify, difficult to manage because of prematurity. The good thing is they're fighters. They have a better tolerance to hypoxia and they usually develop early PE. Late onset, after 32 weeks, difficult to identify. They have a poor tolerance to hypoxia. So I would request all of you to have your Indian charts on your machines, or whichever country you're from, have those charts. 50% of unexplained near-term stillbirths are because of late onset FGR, which goes unidentified. You're basically trying to figure out early FGR, whether I'm looking at the abdominal circumference less or I'm looking at less than the 10th, but with changes in the Doppler. Late FGR, I'm trying to look at 2 out of the 3, weight less, the percentiles going less, or the CPR giving trouble. Now we're looking at stage 1 FGR. That's mild placental insufficiency. The uterine artery, umbilical artery, middle cerebral artery, or the CPR are abnormal. You need to monitor them every week, and you can do a labor induction beyond 37 weeks. It does not mean we need to jump the gun and deliver them. If the problem is just starting, you can still wait till 37 weeks. I'm looking at notching over there. I'm looking at the value which is much higher than expected. In the second trimester, I'm looking at a PI value of more than 1.5. I'm going to calculate the mean uterine artery PI. This is normal umbilical artery diastolic flow. If it reduces, I know I'm looking at trouble. The PI value is increasing. I'm looking at flow which is going more in the brain. That's brain sparing.
I think sir's side is some issue of the net connection.
Yes, ma'am.
To decide. It's not that, okay, I can do it at 24 hours. If the blood pressure is increasing too much, might be we need to be delivering her earlier or taking care. Reversal of end-diastolic flow. Reversal. I'm looking at the ductus venosus flow going down.
Sir, your slides are not sharing, sir. Just now it got.
Sir, slide.
अभी तक नहीं आ रही थी या अभी?
Just now, sir. Just now it stopped screening.
एक सेकंड रुको जी. I'll again start sharing the screen. Might be मेरे से गलती से ना वो बीच में आ गया हो, स्टॉप शेयरिंग का दब गया हो. हाँ जी, कहाँ से नहीं आया मुझे बताओ जी. रिवर्सल ऑफ फ्लो से या एब्सेंट फ्लो से?
सर एब्सेंट फ्लो से दिखाइए ना.
मैं ये दिखा रहा जी.
हाँ.
So we go. Stage 1 FGR was when the problem had just started. Stage 2 is when we're looking. I hope I'm looking. You're able to see the slides now.
Yes, sir.
Umbilical
Yes,
artery,
yes, sir.
Perfect. Ji. Absent and diastolic velocity, we need to deliver them at 34 weeks. This is where we're looking at absent. Absent and diastolic flow, and I'm looking at more flow going towards the brain. Stage 3 FGR, I'm looking at reversal of flow. You need to monitor them every 24 to 48 hours and recommended by a cesarean section delivery after 30 weeks. Reversal of flow. Reversal of flow. This is less flow going in the ductus venosus. Video is moving fine, Ji?
Yes, sir.
Perfect, Ji. Thank you. Now, stage 4 FGR, where there's a high suspicion of fetal acidosis, spontaneous FHR deceleration, pulsatile ductus venosus. You're basically going to be monitoring them. You deliver as soon as possible. Delivery after 26 weeks at a tertiary center. Please remember, in utero transfer of a baby is much better than delivering somewhere else and taking the baby somewhere else. So just be watchful. Looking at bradycardia, deceleration. I'm looking at reversal of flow in the ductus venosus. I know these are problematic areas. Last few slides. If you're looking at a growth restricted FGR fetus and the umbilical artery is started giving you trouble, these are the chances around 6% of perinatal mortality. It goes double if I'm looking at absent and diastolic. And look at here, if the venous Dopplers are going bad, it increases almost 6 times. That's how important venous Doppler is, and do not wait too long as soon as the venous Dopplers start going bad. Reverse flow in the umbilical artery, changes in the venous system, best predictors of severe fetal distress, terminate as soon as possible. Now, how often? Remember, if it's an FGR, there is no point that she takes a huge meal and says, okay, now weigh the baby again. You have to have a difference of at least 2 weeks. The severity of growth restriction is going to dictate the frequency. Gestational age, most important. You're looking at any size of baby. If it's already 37 weeks, why do you want to wait anymore? Why do you want to unnecessarily give yourself and the parents tension? And depending on if the Doppler changes are mild, as I explained, you're going to be repeating it twice a week or every day, or might be twice a day. Gestational age at decompensation is the primary determinant. Now, the neonatal care that you have, if you can't take care of a 1500 grams baby, there is no point delivering a baby 1500 grams. Less than 32 weeks, every day gained is useful. Every week gained, the outcome improves by 40%. Venous Dopplers help in delaying the delivery. More than 32 or 34 weeks, steroids in delivery once the umbilical artery gives you trouble. Now, the biggest dilemma, the biggest question, do you want to give a live fetus or a good, live, well-being, a proper rollicking baby? So it has to be intact survivability. So the risk of intrauterine compromise has to be weighed against the potential risk for iatrogenic premature delivery. You're doing an anomaly scan, you are supposed to be seeing everything in detail. If you're looking at any changes in the uterine artery or very early FGR, you need to be monitoring them very carefully. The moment there's an abnormal biometry, it should trigger a referral for detailed assessment. Is the dating accurate? Any potential factors, maternal or fetal? Hypertension, diabetes, infection exposure, or a karyotype which is giving trouble, or uteroplacental insufficiency. As known to all of you, there are 2 circuits: uteroplacental circuit, uterine arteries, fetoplacental consisting of the umbilical arteries, middle cerebral artery, and ductus venosus. We all have started doing the aortic isthmus. Might be one of these days we take a detailed analysis of the aortic isthmus. A timely referral is most important. It always has to be case-to-case basis. It can't be, these are the guidelines, I'm going to follow those. In the presence of abnormal biometry, maternal symptoms, you need to be watchful of looking for changes in the Doppler. The primary goal of antenatal evaluation is to identify fetuses at risk for intrauterine injury and death so that intervention and timely delivery can prevent progression to stillbirth. Last message, the management of FGR, decision to deliver. It's a delicate balance. You need to minimize fetal injury. You wait too long, you're giving trouble. You deliver early, iatrogenic prematurity, so be watchful. Be careful from your NT scans. Be careful from your 6 to 8 weeks to date the pregnancy properly. NT to looking for the uterine arteries. Anomaly scan to looking for any changes that are happening. Then might be a growth scan at around 28-30 weeks. And finally at 36. Any problems in between, be careful of repeating the scan. And whenever you find that the ultrasound or Dopplers are expensive, just think about the charges that NICU and the trauma that the mother is going through with the baby outside, and we'll find that much better. Thank you so much.
Thank you so much, sir, for such a elaborated presentation. You have cleared lot of doubts. For me, to yes, of course, you have cleared lot of doubts. We can see lot of our friends have joined. So, friends, if there are any questions, you can ask now. So, sir is here for a few more minutes. If any questions, we can ask the sir directly.
I always say if there are no questions, it means two things. Either I've explained very well, which seems unlikely, or I've confused so much कि सबने कहा ना छोड़ दो, बहुत मुश्किल है.
No, sir, you explained very nicely. Look, sir, see, comment has also come from Dr. Neeti ma'am. Neeti ma'am has joined from the Kanpur. Thank you, sir, for a wonderful talk. So, yes, besides that, I am getting other comments also in the WhatsApp also. So, very nice presentation. Sir, Dr. Udyan Dorji has joined from Bhutan. You can see, can you mention normal CPR?
See, you can go into the ECOG charts or the FMF charts and see that. But what I follow is if the CPR value is more than 1, that's normal. If it's less than 1, I take it with a pinch of salt. But depending on whatever you want to take the percentiles, that's also fine. But I normally have a ballpark figure of more than 1 or less than 1. So I just see the umbilical artery. If that PI value is more than the middle cerebral artery, I know the denominator is more than the numerator, so the value is less than 1, and I need to be thinking of delivering. In fact, there's this famous thing. I was sitting on a craft, and one of my students rang up and said, the CPR has come out abnormal. I am 32 weeks. Can I wait for 3 days? I said, nothing doing. You have to deliver now. And she delivered. That she was 34 weeks. She delivered. By the time I reached the other place, and I had a message from her husband that things are fine and is glad we delivered early. So never take a chances with CPR. They can just give us huge surprises.
Great, sir. Thank you for sharing this also. Good to see Dr. Baba Saheb Munde, a very dear friend, a very renowned surgeon from Pune. Thank you for joining. Okay. And another comment is from Dr. Shikha. Sorry. Yeah. I have missed, I think, her comment. Yeah. Is accurate, is according to gestational age. Just a second, I'm not able to read properly.
Yeah, that's what I said. The CPR can be a little different if you're looking at in terms of the percentiles. But to take a ballpark figure, I take it less than or more than 1. Otherwise, you can always feed these values, and the computer, the Google, according to the ECOG guidelines, is going to calculate. The moment it is less than the 5th percentile, you need to deliver.
Yeah, you can speak, Dr. Munde, you can speak. You can unmute and speak. He has raised his hand. Kanchan madam is saying great presentation. Yeah, thank you, Kanchan ji. Of course, sir's presentation is always great. Can I unmute him?
There's a question from Dr. Wisam. Yeah.
Yes, Munde sir. How are you?
I'm fine. Thank you, madam, for giving me such an opportunity, and I have enjoyed the lecture. I just want to know from sir that if you do anomaly scans or any ANC ultrasound for the baby, if you find that baby's kidneys are still not developed as per your marks, then what do you suggest? And did you find any abnormality in the ultrasound and then baby is delivered normally? Or matlab normally, I mean to say anatomically normal.
See, those things can definitely happen. We need to know exactly when is a structure going to be developing. If I'm looking at 16 weeks, I'm not supposed to be mentioning or commenting on the cerebellar vermis. I'm not supposed to be commenting on the corpus callosum. Somebody just sends me for a detailed anomaly scan at 18 weeks. I tell them I'm doing this, but these two, three things you need to come back again. The development of the kidneys, especially hydronephrosis, you can see them increasing. The pelvic tissues can increase, and by the time they're born, they just becomes normal. So there are plenty of such things that can happen, but you need to be having a protocol, a scientific basis as to whether these things can go bad or right. We are not supposed to be suggesting them. We are supposed to be telling the patient the facts about it.
Thank you. Thank
I
you very
hope,
much, sir.
yeah, sir.
Yes, you have elaborated away, matlab the point well, and we have enjoyed the session also very well. So thank you very much for such a beautiful and wonderful session.
Thank you.
Back
Thank
to
you
you, sir.
so much. Thank you so much, Dr. Munde. There's a
Now,
question by Dr. Visa Milage. Is there a place for umbilical artery Doppler in cases of preeclampsia without FGR? See, again, without FGR, it's not going to be that helpful, but it is just going to tell us, am I going to be looking at any trouble? Am I looking at any fetal compromise? So that's a good way to really know about doing these Dopplers. So even if there is no FGR, might be you could be finding, because of the acidosis, because of the hypoxia, changes happening in the umbilical artery, middle cerebral artery, and finally the venous waveform giving way. Then there's a
Saidi, please
question.
take the question.
Should I read the questions, Dr. Ritu? Dr. Shivani's asks, what is the centile of umbilical artery PI taken as abnormal? See, if the middle cerebral artery PI goes less than the 5th percentile and the umbilical artery goes more than the 95th percentile, is when we regard it as abnormal. Then finally, if you're looking at absent or reversed, that is definitely abnormal. I hope all of you getting your questions answered. If there's still any doubt, just mention that so that then I can reiterate.
I'm sorry if the net connection was unstable. That's why my
Maybe no
screen was
problem.
get blurred.
I was holding the
Doc-
fort for your sake.
yeah,
Then there is,
yeah. Doctor,
is
let
there,
us first know from where Dr. Vesam has joined. Dr. Vesam Elga has joined from where? Yes, we are going to take the other questions also. Yes, sir has already answered the two questions. Yes.
then Dr.
Uh,
Ugyen Dorji is asked, is there any international protocol or formulas to calculate the RPOC volume? See, RPOC, I hope this is retained products of conception. Retained products of conception, depending on if she's taken medication or she's gone through a procedure, how many days after that. And again, if you're looking at, that's where Doppler is going to help you. If you're looking at a warm to hot vascularity and you're looking at a beta HCG, which is still on the higher side, you definitely know the products are there and something has to be done about it.
yeah. Thank you, sir. Sir, there are more comments. Dr. Rashmi is writing that she was not able to join the starting, how to get the recording. The program has gone live on my YouTube channel. You can put the Dr. Ritu Santwani, you can get all that, all the programs. Sir, I have received one question. Actually, the doctor doesn't want to give the name.
There is no
The
problem.
question is, how is FI related to abnormal Doppler?
How's A5?
How
I had shown in a screen that you're firstly going to, basically what is really going to happen. There is going to be hypoxia. There is going to be aortic body chemoreceptor stimulation. there is going to be less blood flow to non-vital organs, more blood flow going to the vital organs. Which is the vital organ? It is brain, which we can see that by the middle cerebral artery. The other vital organs are suprarenals and heart. The non-vital organs are the lower limbs and the abdominal viscera. So the moment it is less to the glycogen stores, the baby becomes FGR. If less is going towards the kidneys, you're going to have oligohydramnios. If less is going to the intestines, this baby is going to be subjected to necrotizing enterocolitis. Less flow goes to the lungs, it's going to be respiratory distress syndrome. So that is how these things are interrelated. I hope I've been able to answer the question which the doctor had asked for.
Yes, sir. Yes, sir. Yeah. Besides this, all the appreciations we are getting. So I think there are no more questions. So with this, we will wind up because it still started a very heavily, and I don't know whenever my net will go. So thank you once again, sir, for enlightening all of us.
Pleasure,
May
Ritu,
I
for
request
taking up these
Saiti,
topics. In fact, somebody's mentioned a good topic selected by Dr. Ritu. So thank you so much. It's always a pleasure to be
Thank you,
in
Ritu
these
sir.
forums. Thank you so much.
So,
Thanks.
so nice. Sir, this is a small token of appreciation from our side, a certificate of appreciation for contributing as a distinguished speaker for 21st September 2024. So thank you
You take
so
out
much,
a
sir.
hard copy. I'll come to Pune and collect it. Not to worry.
Okay, sir. My pleasure and honor. With this, friends, we are going to wind up for today. And I will be back soon with another series. But probably tomorrow I will declare for the another week program. So with this, a good night to everyone, friends. Bye-bye.
Thank you. Thank you so much.